Environmental. Probably gonna have a subject matter expert on some of this stuff. So chime in. Huh? Yeah, so seriously, chime in with like patients you've had or anything that I don't talk about. All right. Guys, there's gonna be a lot of things that kind of encompass these environmental injuries. What patient population across the board or population are gonna be more susceptible to these environmental injuries? Okay, so pediatrics, geriatrics, and
18-year-old males.
18-year-old males. Andy's not 18. Males.
Yeah.
So maybe that's just trauma across the board. Hey, y'all, hold my beer, watch this. Mentality, yeah. So pediatrics, geriatrics, and immunocompromised, right? Because that's the common theme. All three of those patient populations are going to be more susceptible to medical emergencies, especially here with these environmental. Okay. Talk about all of these. Guys, what are some things that go into considering if my patient is going to be able to handle environmental emergencies better than others? Okay, so overall health of the patient. Do they have a lot of comorbidities, right? What else goes into that? Okay, patient size. Are they rather large or are they teeny tiny? Because both of those things can have pros and cons depending on what environmental emergency we're talking about. All right. Age, we talked about that. Peds and Jerry's. Nutrition and hydration. This is a big one. Okay. If your patient, let's say, is going on a hike and they get lost or they fall and they run out of food or water, that's going to drastically increase the amount of time that these patients, or I'm sorry, I guess decrease the amount of time that these injuries or these exposures will become fatal. Okay, if you're dehydrated and exposed to environmental emergency, it's not going to bode well for the outcome. Okay, same with nutritional status. All right, temperature obviously is going to affect. All right, let's talk about cold exposure first. All right, what are we going to see more so with cold exposures? What kind of injuries? Okay, so overall hypothermia. What else? Frostbite, frost nip. Okay, so we'll see whole body hypothermia, and then we'll see typically the distal parts of body areas that are not covered up or exposed to the cold. Guys, be familiar with these 5 ways that the body can lose heat, because they're going to go into how you find your patient and how concerned, how far progressed are we with this hypothermic state. Okay, so conduction. All right, this is what? All right, so direct transfer. Okay, so give me an example of conduction. All right, so if you are barely clothed or you don't have a lot of clothes on and you fall onto a cold tile floor during the winter, okay, that direct contact to that cold surface is going to further cause your body to lose heat. All right, convection. Air. All right, if it's super windy outside and your body parts are exposed to the cold atmosphere, that wind is going to drastically increase the amount of heat loss going over your exposed skin. Okay. Evaporation. If you're wet. Is it good to be cold and wet?
No.
No. All right. So that's going to go into a major part of your management of these patients if we're suspecting hypothermia, is if they have on any wet or saturated clothing, we do what?
Yeah.
Cut it off. You might think that that's counterproductive, because what if it's a pair of pants and 2 shirts and a jacket? You think that we need to leave clothes on them, right? Not if they're wet, guys. So the whole evaporation thing, if you find a patient who is hypothermic and is wet, we cut all of those clothes off, and then we do our own controlled environment in the back of the truck, cover them with dry blankets, crank the heat up, all that jazz. Just because it's long clothing items Doesn't mean we leave them on if they're wet. Radiation, just standard. There's not really the best example I can give.
They're wearing like a neoprene like wetsuit.
Okay, then they're not going to lose much.
Ruin that.
That's true. That's true. And respiration. It's probably not something that a lot of people think about going into contributing to hypothermia. Right? What happens when we breathe in? Okay, air comes into our body. We can breathe through our nose because if we breathe through our nose, what three things happen more so? Humidified, warm, and filtered, right? But guys, if you're outside on a 30-degree day and you breathe in through your nose, that's not going to warm that external air up to 98.6, maybe a couple degrees, okay? So if you're outside breathing in cold air, you're introducing that cold temperature through the air to your body, all right? Also, when we exhale, what temperature is that air? Warm. So it's a combo. We're gaining more cold air and we're blowing off more hot air. So actually physically breathing can change the amount of time that the patient can succumb to the cold environment.
Hey, Instructor A,
Yes.
would you mind pushing the camera up a little bit?
Sorry, guys.
Thank you.
All right. So guys, all of those things factor into how significant the cold exposure is, how long the patient can kind of sustain the life status, the hemodynamic status, if they're wet, if they're improperly dressed, if they're lying on a cold surface. Okay, all those things go into it. What's another thing we want to know? Yeah, guys, how long have they been there? Right? Have they been there 30 minutes or have they been there 3 hours? Big difference. Okay, sometimes overnight. Doesn't usually bode well. But how long have they been out exposed to those elements? Okay. So guys, what is the definition of hypothermia? Okay, so a low temperature, so less than ideal temperature. What's our normal body temperature? Average. 98.6. Okay, guys, it sometimes can fluctuate down to like the 97, sometimes can go up to the 99, but anywhere in that average range is ideal for bodily functions, for that hypothermia or the homeostatic state. Okay, we don't like to go too high or too below that. But technically, if we go below 95 degrees, it doesn't seem that much, right? That's only 3 degrees off. That's how sensitive our body is when it comes to temperature, okay? What is a misconception about hypothermia?
Warm them back up.
That you can just warm them back up, okay? But maybe more so, what is a misunderstanding about who falls victim to hypothermia? Okay, it's got to be somebody who is outside in like 30-degree weather for hours and hours on end before they can go into a hypothermic state. That's not true, guys. It depends on your patient's age, their overall health, and all of those 5 different kind of elements that go into it. If you are exposed to a temperature that is technically below your body temperature, you can technically become hypothermic. All right, if you've got a geriatric patient who has like no adipose tissue, is not in great health, what also starts to deteriorate the older that we get? Okay, so sensory thermoregulation. That's why if you ever walk into like an elderly person's house, especially if it's like a frail little old grandma or grandpa, even if it's in the summer, they got the freaking heat on in their house, right? So if they're outside on like a 60, 70-degree day, they don't have a lot of clothes on, there's not a ton of sun outside, there's a constant wind blowing, and they can technically go into hypothermia. All right, so don't just assume that it has to be like frigid winter temperatures for these patients to go into that state of hypothermia. It could be, you know, a spring day or a fall day if all of these different factors are coming to the ideal situation to cause hypothermia.
Do you typically find them when they're outside when they do that, or is it they fell down, kind of laying on the floor?
Usually it's falling down. And guys, that's the biggest one, especially with these geriatric patients. That Life Alert commercial, no, I'm falling and I can't get up, right? They fall, they dislocate a hip, they have some type of significant orthopedic injury, like a bone in their leg. They can't physically get up to reach a phone or to let anybody know, hey, this happens. It's inside in a climate controlled, you know, environment. But if they're on that cold floor, that is a very common cause of these patients going into hypothermia. So yeah, just keep that in mind. Just because it's not 30 degrees in the middle of December doesn't mean your patient can't be hypothermic. Fair enough? Yeah, cool, okay. Guys, what does cold do to the body? Slows everything down. If we get too slow, what can happen?
Stop breathing.
You stop breathing. Your organs start functioning, and you can die from hypothermic state. Okay, typically that's you succumb to the elements. Is that what they term it as? If you die from like heat exposure or hypothermia, all that stuff. Just talks about that. Yeah, guys, especially here in Atlanta, when we get to those winter months, we have a very big homeless population. Okay, they are not in climate controlled places. They are exposed to the outside temperature. If it's raining on top of being windy, we see a lot of homeless patients who either succumb to hypothermia or have significant hypothermia related injuries. Once you guys get on a truck during the winter months, you will see that if they call for like a particularly cold forecast, they will open up extra room in all the shelters to try to get the people off the streets so they don't die of hypothermia. But you're going to see that a lot during the winter here in Atlanta with the homeless population. Swimmers, yes, if you're swimming and it's cold outside and you stay wet, you're more prone to hypothermia.
Or even if it's not cold outside, the water's probably not.
There you go. There you go. All right, so guys, here's just how our hypothermic state can start to progress. Guys, even that 95 to 93, we start seeing what? Shivering. Why do we shiver?
Your body's trying to warm itself back up.
Recognizing, dude, it's freaking cold. This is not conducive to me living and thriving, right? So it causes your muscles to tense up. A byproduct of motion is heat. All right, so shivering is your body's attempt to warm up that core temperature. Okay, that's why Bear Grylls and all of their survivalist shows, if you were in a cold environment, they, recommend that you never stop doing what? Moving. Because I'm not talking about like jumping around doing jumping jacks, because we don't want to move too much because we might start doing what? Sweating. And then that whole like evaporation thing plays in. If we're sweating and it's really cold outside, then that's not going to bode well. But yeah, just like walking around, they say the second that you sit still and it's cold, you stop moving, you stop having that heat. That's usually detrimental. Okay. We start to see some constricted blood vessels. So vasoconstriction. Why? What's my brain thinking? This is cold. Hey, fingertips, hands, feet, you're really cool. I like having you around, but I can live without you. And we do what to the blood? Shun it to the vital organs. Okay, because blood is what? In nature, it's warm. All right, so shunning that blood can help preserve the integrity or the temperature of brain, heart, and lungs. Okay. Start to maybe see some withdrawal, maybe not technically confused yet, maybe just lethargic. You might be ANO times 4, but you might be slow to respond. Okay, guys, if I get to this point where I'm like shivering, it's hard for me to control my mouth. Like my lips get so cold, like I start sounding like I'm, drunk, like just slurring my speech. So that might lead to the kind of takes a while to respond to you. 89 to 92, we start to see everything start to slow down because we're breathing in rapidly here. We're trying to do that compensated shock or the compensation method. Everything starts to really slow down when we get to this 89 to 92 range. we start to see the beginnings of altered mental status at this point. Okay. Further progressing 88 to 80, you're going to be unconscious, unresponsive. You're not going to have any type of ANO times 4. Your brain's not going to be functioning to the point where you can communicate. Again, we're slowing down even more in this 80 to 88 degree range, guys. If you're less than 80, you don't really come back from that. That's significantly hypothermic. Okay.
Isn't the record like 64 though?
That I don't know. No, guys, there are just crazy cool cases. You hear about it. I think there's been a couple movies made about some of these instances where somebody falls through the ice, and they are underwater for like 10, 15 minutes before they pull them out, and they eventually make it. They come back to life. Why is that? Why do some of those freak stories happen? The mammalia diving reflex. What is that? So if you have a sudden, extremely cold stimulus to your face, the brain kind of goes into a kind of shutdown hibernation mode, if you will, and slows everything down like pretty quickly. So we don't have that slow deterioration of the organ function. It's kind of like literally you go into hibernation mode, everything gets really cold, it slows down, almost non-existent, and then you have the ability to kind of warm back up gradually and get those organs functioning back to their normal state. But yeah, that's called the mammalia diving reflex. If you have a cold stimulus, you go instantaneously like to a bradycardic state to try to preserve your organs. We actually, no, I can't. Mammalia,
M-A-M-A-L-I-A-N probably.
Yeah, mammalia diving reflex. We actually use that approach if a patient has a really fast heart rate, like if they're in a rhythm called supraventricular tachycardia, SVT. Before we give them medication that can slow their heart rate down, we'll put like cold packs around their face to try to stimulate that diving reflex to lower the heart rate before we do any kind of drastic intervention. Yeah, because guys, there's actually, we don't do it anymore at Grady because the studies were a little conflicting, but there is, they treat patients who go into cardiac arrest sometimes at different hospitals with a hypothermic approach. I think they still do it in the ER at Grady. We don't do it pre-hospital anymore. But if you bring someone who is in cardiac arrest and they get them back in the hospital, or you got them back en route, they will push cold fluids through their body. They'll put them in a state of hypothermia so they can gradually warm the body back up, and it's not as kind of like the shock value for the organs, like going from one extreme to the other. So there are some benefits to hypothermia, but they have to be controlled, kind of ideal happenstance. Guys, again, CCT, that T is the temperature when we assess the abdomen. Make sure, guys, if they're extremely cold, you got to gauge too. What? You got to throw the factor in of your environment.
Cold no matter what.
Okay, what else? Maybe what's their baseline? What about your baseline? Yeah, my hands are always freezing. So I could come up to somebody who could technically be hypothermic, and I put my hand on their abdomen, and I'm like, yep, feels about normal. Because you got to take in consideration the temperature of your hands and how their temperature might be perceived to your hand if it's hot or cold. All right, we already talked about that, the mild hypothermia. Guys, this is just all of your, that chart that we talked about, just in text form, so just be familiar with that chart. All right, guys, your patient is not dead until they're what? Warm and dead. All right, that's a big saying you guys have to understand and work with and work around, and especially in a pre-hospital setting, because of that mammalia diving reflex. It is highly unlikely that if you get on the phone with medical direction, if you have like a cardiac arrest patient and you're performing CPR out in the field and it is in a cold environment, like if it's in the winter, if you call med control, you guys can't do a field termination. But if your medic calls med control and says, hey, we got this, blah, 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 that doc on the phone is gonna be like, are they exposed to like a hypothermia situation? If we say yes, 9 out of 10 times they're gonna be like, nope, I'm not giving you permission to call it, you need to transfer them. Because they're not gonna be dead until they warm their core body temperature up in the hospital to normal. And if they still don't have a pulse, if they still can't get them out of cardiac arrest once their core temperature is normal, then they'll say, hey, yeah, we're calling it. Because of that preservation mode that can be enacted in some of these hypothermic patients, your patient is never dead until they are warm and dead. Keep that in mind. So localized cold injuries, guys, typically, again, they're going to be on the distal parts of these body extremities. The nose, the ears are a really common one, fingertips, sometimes toes. Why do we see it like the frostbite and all that stuff more so in those areas? Yeah.
That's where heat mostly escapes.
So maybe heat mostly escapes, but it's not as covered up, right? You can't like wrap your entire face up. You can't like put 7 different layers on your nose like you can your core. All right, so they're not as protected as much from these external temperatures. Again, guys, all these things are going to go into consideration. How long was the exposure? Was the area wet? Was it covered? Any of the evaporation, conduction, convection, all of that stuff. Patients who have, again, pre-existing health conditions are more exposed to having issues secondary to hypo or hyperthermic environments. Alcohol and drug use also. Why?
It speeds up your heart rate, it causes vasodilation, you're gonna have more blood radiating, heat off.
Okay, so we have more blood flow that goes to the surface of the skin when we have that alcohol and drugs on board, depending on what drug. But if the blood is rushing towards the surface area of the skin, it's not keeping what warm. Okay, your core. Also, too, it delays your sensory perception, right? It might be really cold outside, but you're warm and toasty on the inside because you've had some whiskey, right? And you're like, no, I feel great. It feels lovely out here. And you're not aware of the actual temperature and exposure, right? What else?
It impairs your ability to thermoregulate.
Okay, so impairs your ability to thermoregulate. What else?
There's a decision-making process to maybe go voluntarily thermoregulate.
Okay, so maybe it sounds like a good idea to your brain when you've had all that whiskey. Hey, let's go skinny dipping. Something like that, right? Let's go make snow angels or something. All right, what else on the drastic end of the spectrum? Yeah, what if you black out? Or if you are using drugs to the point where you go unconscious, unresponsive, and you're sitting on that park bench and it's 7 p.m. and nobody finds you until 7 a.m. All right, so a lot of things go into that. Frost nip, again, this is going to be the very beginning stages of this cold exposure to the skin and the soft tissue. This is typically not a major concern for us. It's typically not even that painful. Doesn't really cause any lingering side effects. Again, ear, nose, fingers. Immersion foot, what is this? Kind of like trench foot, but we're throwing the cold aspect into it, right? If your feet get wet, like for hikers, they always tell you invest in really good boots. So if you're getting in the water, that the water is repelled, it doesn't seep down into like the interior of your boots or your socks, because once your feet get wet,
It's over.
it's over. It's in that confined space, right? Especially if it's cold, we can start to see some degradation to the skin tissue itself. If it's cold, again, that evaporation effect speeds up that hypothermic process. Skin of the foot, again, it's going to look all wrinkly. It's going to look all pruny and pickled, like if you stay in the bathtub too long or in a swimming pool too long. Gonna be pale typically with this frost nip. It's gonna be cold to touch. But then we're gonna progress into the frost bite if we don't remove said frost nip areas from the cold, dry off that skin tissue or that soft tissue. This is gonna be the progression, is frostbite. What's happening here? Why is frostbite bad? Huh?
The cells are actually lysing because of the cold just shattering them basically.
Yeah, so we have a couple of different things going on here. What have we already said is gonna happen if we're to this point of hypothermia? What's happening to our blood flow?
Not there.
It's gonna get shunted to your major organs.
Okay, so we're not gonna have as much blood flow to the distal extremities, right? And we already said blood in nature is what? Warm. So that's gonna be less warmth that we have to these areas, less blood flow. And then, yeah, guys, the tissue actually starts to crystallize and to freeze. All right, that combo is not gonna be conducive to perfusion and having that tissue of the area remaining alive, okay? So you will actually start to see the blackening of the area. That's gonna be a little further progressed. That's gonna be actual like necrosis of the tissue. How else is this gonna present? Not another picture. I thought there was another picture. Hard. Like it is the most off-putting thing when you go up to a patient. Guys, seriously, if you took an area that was frostbitten and you knocked it on your table, it would sound like you were taking like a completely solid object and just tapping it on the table. Yeah. All right, so very hard, has kind of a waxy, like a sheen appearance to it. It's really, really weird. It almost looks to the point where we get that necrosis, the blackness, like mummified tissue. It's really weird. There's a Levophed. There, if the patient is on Levophed, it's a vasoconstrictor. If they're on that medication for too long, especially in like an ICU setting, they can actually lose extremities because it shunts to the core and it takes away the blood flow from the extremities. And it literally, there were several patients who had contact within the ICU that it was just black and you would just tap it and it would feel like you were tapping like concrete. It's really weird.
So that's not disturbing.
Huh?
I said, well, that's not disturbing.
I know. It's either lose a leg or lose your life. But yeah, the same with that medication would be Levophed, leave them dead, because it would be leave all of their extremities dead type thing. It's really gross. We might see blisters and swelling. Could be red, could be pale, could be purple. This black skin color is not really going to present itself until we've actually had like the necrosis of the tissue. So superficial frostbite, the skin itself is frozen. If we have that deep frostbite, the actual underlying tissues and structures are frozen. You guys ever like thaw meat out? Like if it's from frozen, like you're about to cook it. So the inner core of that meat remains frozen when the outside starts to kind of thaw out. That would be like a deep frostbite. But then you would also have the skin as well. Guys, how do you treat frostbite? Okay, we don't want to warm it up.
Slowly. We don't want to like run it under water. Bring it into like a warm environment.
I think, hold on. I think it says. Immerse the frostbitten part into water that's between 102 to 104 degrees Fahrenheit. Are we gonna have that in the back of the truck?
No.
No. Guys, typically if we have an area that is frostbitten, we do what to it? Leave it alone. We can try to actively warm the rest of the patient's body up, right? If it's wet clothing, we'll cut that off. What are we gonna do in the back of the truck? crank up the heat, let's get some dry blankets on top of them. But we're typically gonna leave that frostbitten area alone. We are not gonna handle it a lot.
You should, ever, rewarm frostbite, because A, it hurts like a lot, and B, you can literally kill them.
Why can you kill a patient from rewarming frostbite? Especially because, guys, what do you do when your hands are cold and you're outside? Right? That friction, try to heat it up.
Yeah, don't do that.
Should we do that to a frost snip or particularly a frostbitten area? If they've got like the
Nope.
just warm it up for you. We got this.
Nope.
Why? What can that do?
Damage on the tissue because it's frozen, so it's already on the frozen.
Okay, so the tissue's already screwed, right? We're to that frozen crystallized state. So technically, yeah, you can, but what's more likely that you're gonna do?
You can actually start causing more physical damage.
How? Like, how can you kill a patient by doing this?
They can go into shock, possibly.
What kind of shock?
If you hadn't asked me, I would have been able to tell you, but I know it's shock. I can't remember which one.
You're gonna be hypovolemic shock or obstructive shock, but I'm not sure which one it's gonna be.
Well, which one is it?
Is it similar to like the crushing syndrome?
Mm.
Body has nothing to break on.
Mhm. So, yeah, guys, this is the same where we can create emboli by doing this to a frostbitten area by breaking off some of that crystallized, hardened skin tissue that can break off and get in the bloodstream and go get stuck somewhere. Okay, so we can actually create emboli when it comes to like trying to rub or manipulate or handle a frostbitten area. So actively rewarm the rest of your patient's body, but typically, guys, we leave those frostbitten areas alone. You can maybe consider like wrapping up with dry gauze if we've got some intact skin, like if the blisters are there, if it's red, but we're not going to do any significant handling of those frostbitten areas because we can cause a lot more damage.
That's what I was about to ask you too. And another thing, I don't know if I missed it or not, but let's just say we do have a patient who has a frostbitten, I don't know, leg or something. Is there like a particular positioning we need to consider when we load them into the truck, or we just go ahead and lay them like the appropriate manner based on how we find them?
Yeah, so position them appropriately. Guys, what do we not want to do?
Shake the popsicle.
Do not shake your popsicles. If you have a patient who is significantly hypothermic, you need to handle those patients with extreme caution. Why? What can you do if you're just, oh, this patient's hypothermic, you know, we got a popsicle here, you just grab them and you toss them and you're just kind of like manhandling them, you're jostling them, the stretcher's bumping up against everything. What can happen? What will happen? You can put them into V-fit. Okay? This one wasn't my fault, but I've had this call. Before I upgraded to paramedic, I was working with another medic. We got a welfare check. It was like January, February. It was really cold. It had been cold the past couple of days. We got a welfare check from a neighbor. The basement door to this house had been open for like 24 hours. And they were aware that there was an adult patient who had some mental and physical disabilities that was cared for by this family who lived in the basement. That's where they stayed. So they wanted us to check and make sure everything was okay. Fire didn't get called out because it was a welfare check. We walked in and it was absolutely nothing on the interior of that basement except a concrete floor and drywall. This particular patient was laying in nothing but an adult diaper on top of a like twin size bed with a sheet. Dude was a popsicle. He was extremely hypothermic. Dude was probably like your height. a little skinnier because he just was not getting, this was definitely a neglect case. But it was myself and probably someone the size of like Libby, another female crew. And it was very challenging for us to try to get this patient moved and up an inclined driveway. And of course, fire wasn't around. Fire couldn't respond. We couldn't have any additional units responding because everyone was busy. So he went from being extremely hypothermic but still alive and had a pulse to all of that jostling about 5 minutes down the road after we started transport. My partner says, hey, you need to pull over and call fire. He's in cardiac arrest. You're gonna have to come back here and help me do compressions. So we put him into VFib with all of the movements of the popsicle. Don't shake your popsicles or they will go into cardiac arrest. All right.
What happened to him?
He didn't make it. But there was no quality of life. The way that he was existing, he had a peg tube. It was just, yeah, it was a really bad situation. But yeah, he didn't make it. If your patient's hypothermic, how often are you reassessing your vital signs?
5 minutes.
Do you think we're always going to be able to get a very distinct blood pressure when it comes to hypothermic patients? No.
No.
So keep that in mind. What's that sixth variable we want to add in there? Temperature. All right, guys, where's the most accurate place to measure a temperature? Rectally. Okay. We don't have rectal probes on the truck at Grady. Some pre-hospital services might. They do have them in the hospital. We have the little forehead stickers. All right. We used to have the little plastic, we would take it orally. Guys, if you take a temperature axillary or orally, what do you have to do? You need to add a degree to the actual reading. Okay, so if you take a temperature of somebody who you think has a fever, you get an axillary measure of like 101.2. Realistically, it's closer to 102.2. All right, so same with here and orally. Rectal is very, very accurate, but we don't always have those on the truck. Guys, if my patient is altered, if my patient is cold to the touch, do I, in my time with the patient in that pre-hospital emergency setting, really care about an exact number? No, because we're managing.
Life threats.
We're managing life threats. We're managing AGCs. We're trying to rewarm the patient, and we're managing them, how their signs and symptoms, how they present. All right. They can control the temperature of the patient better in a hospital setting, but if we have a rectal probe, that's going to be your best bet to get an accurate temperature on these hypothermic patients.
Taking BGL, not necessarily frostbite, where is a better locality?
At that point, guys, because again, what's happening with the blood? It's shunting, so you might not have appropriate blood flow to the distal tips of your fingers. Where can you try for? Earlobes is usually the second place. If you can't get an adequate amount of blood from fingertips, you can go to the earlobe. Take the earlobe because that's much closer to the core than your fingertips are. Dun, dun, dun. Give O2. Cut wet clothes off. Guys, Jack, you should be sweating bullets by the time you get to the hospital if you're transferring a hypothermic patient. You should be sweating bullets by the time you get to the hospital if you're transferring who else? So maybe shock patients, right? We're going to warm that up. But I mean like max heat capacity. Who else? Significant burns, right? If we have like a high BSA of like a 3rd degree burn, you're going to be sweating your britches off by the time you get to the hospital. You should be. Okay. Ideally have them, if we can cut the clothes off and like remove the clothes from the back side of the patient, have them on a dry sheet on the stretcher. That's ideal. Sometimes it's not always feasible, but try to make it a dry blanket sandwich, right? Dry sheet on the stretcher, patient, and dry blankets on top of them. Again, don't massage frostbitten extremities. Don't allow the patient to eat or use any stimulants. Don't say, hey, yeah, I know you're cold. Here, take some crack. You'll feel better. Don't let your patient do that. If we can give them warm humidified oxygen, guys, we typically can give humidified oxygen in the back of the truck, but controlling the temperature is not going to really be in our wheelhouse. Talked about that. All right, we can apply heat packs if you have them in the truck. All right, how can we do that? Where should we do that? How should we do that? Okay, so we want to try to warm up the core as best as possible. All right, so we talked about the cold packs earlier. They're in little plastic bags. You kind of punch the contents, you shake it up, and then all of the stuff on the inside starts to get cold. Same thing with a heat pack, all right? So if we have heat packs, we want to place them in the junctional areas, right? We can put them in armpits, we can put them on the groin, and we can put them on the neck. That's going to heat up any of the blood that's passing through those junctional areas that is providing perfusion to the core. It will gain more heat by passing over or under, if you will, those heat packs, those hot packs. Okay.
Get the warm fluids on mouth. Actually,
Just, this is going to be depending on your setting. If you're 2 hours in the wood, you're a 2-hour hike or 2 hours from any kind of significant transport, yeah, if we have warm fluids, we can get them to kind of actively warm themselves up. But if you're, 10, 15 minutes from a hospital, we're not going to give them anything PO. Hey guys, what's the first thing we need to do? Like one of the first forms of treatment?
hot and cold.
Get them out of the cold, right? Like, let's expedite. Yes, we're going to manage life threats. Yes, we're going to manage ABCs, but as soon as we can, get them out of that cold environment and get them into the back of the truck. Because you can do what in the back of your truck?
Yeah.
You can control your environment in the back of the truck, right? So that should be like one of the first and foremost things after ABCs and life threats. All right, let's get them on the stretcher. Let's get them loaded up, and we can do the rest. We can cut off clothes, all that stuff in the back of the truck after we turn the heat up. Obviously, guys, if there's any, hold on. Immersion foot, again, guys, remove the shoe. If you should have decent enough trauma shears, or if we need to remove the shoe of the patient, you can cut down like the lace line and then kind of like peel it off both sides, so we're not causing any further damage or any further like manipulation of the foot. But remove that, remove socks, dry off as best as we can. Yeah, guys, this is not ideal. Never attempt to rewarm if you have the possibility that it's going to freeze again. If you're out in the woods and you come across 103-degree water, don't put it in there, because if you're not close to transport, it's just going to freeze again. Hopefully that's common sense, everybody, but cold exposure and heal. Guys, you got to dress in layers when it comes to working outside in the wintertime. Just get like long johns or like leggings to wear underneath your pants. You can wear a shirt underneath your uniform shirt. Use your provided jackets when it comes to uniforms. You can wear like skull caps or boggins or beanies, as long as they're like a solid black in color, or if they're uniform issued. Just again, you guys have been around for a couple of winters, right? You know how to dress accordingly for the cold. Okay, just make sure. Okay, guys, let's get through the heat, and then we'll take a break, and we'll come back to like bites and stuff.
Can I do a little spiel on hypothermia?
Huh?
Can I do a little spiel on
Yeah.
hypothermia? Not necessarily like if you're working on ambulance, since you're just gonna go to the hospital. But if you're like camping somewhere, or like one of your friends is just cold, you can't just like warm them up. Like you can't like give them a blanket. Like you're gonna be okay, dude. The only really effective way to warm someone's body.
Here we
is,
go.
Sugar.
Okay.
They have to warm themselves from the inside. So like, unless they're unconscious, give them a candy bar, like some hot chocolate, and prevent additional heat loss. But like, you're not gonna like wrap them up in a sleeping bag, and then they're just gonna magically get warm. They have to warm themselves.
I thought you were gonna have the old pickup line. The only way to increase your body heat, snuggling without clothes on.
So it have to be thinking,
Yes, exactly.
but also that just gonna prevent further heat loss.
All right, everybody good on cold exposure, hypothermia, frostbite, managing, treating your patients with said issues? Okay. All right, so heat exposure. You might see some of this. You're going out to clinicals during the heat of the summer. Pretty sure, did I see that did they cancel the Peachtree road race? So wrong. Yeah, guys, typically with a Peachtree road race, yeah, Kayla, it would have happened this weekend. But we see a lot of heat injuries, especially like if people are physically exerting themselves out in the heat. So let's see, we start to thermoregulate when it's hot, ideally first and foremost by sweating. All right, so we have that whole evaporation concept, right? We moisten the exterior epidermis, and then any type of movement of like a breeze or
I found this on the
motion
web for exterior epidermis. Check it out.
Sorry, guys.
or any movement of your body, or if there's a wind, a cross breeze that cools off your body temperature by having that whole the moist aspect, the evaporation. Dilation of blood vessels. What is this? Why does this happen?
Now you're trying to get the
Like,
blood
yeah,
to a surface level.
trying to like release it.
Okay, so trying to kind of offload the heat of the body temperature through the pores of the skin. Removal of clothing and relocation to a cooler environment, guys, just with the cold patients, all right? First and foremost, after we assess or manage life threats and ABCs, what do we need to do? Get them in the back of the truck, because we can do what in the back of the truck? Crank up the AC. Okay, if they have several layers on, all right, when might we see this patient who is overdressed for
They're usually working out.
Okay, so maybe working out. What do you mean?
A lot of people that work out, they usually put on like those what's the things called? The little thermal bag thingies, like they like trash bags.
So not like a sweatsuit in the sense of that's what you wear at home and sit on the couch and watch Netflix, but literally a sweatsuit. It's non-permeable material. Sometimes you see people wrap trash bags around them.
They're purposely trying to increase the amount of sweat of their body to burn fat.
A lot of times you'll see like wrestlers do this. If they need to meet their goal weight and they need to lose weight very quickly, they'll do it through water weight. Okay, so yeah, definitely something like that. What else?
I'll be honest, maybe like firefighters, but I don't think first responder has to wear a full uniform.
Okay, yeah, guys, one of the worst heat exhaustions I've ever seen and dealt with was a firefighter. We'll come back to that. What else? Who else? Geriatrics. They are very heat sensitive. They don't like to be out in the heat at all. Children.
Because mama wraps them up.
Mama wraps them up. Okay, yeah, maybe.
Like altered mental status.
Altered mental status. Guys, sometimes we see this with the homeless population. Why?
Can't leave it somewhere.
They don't have a closet, right? If all of the clothes that they have, literally the clothes on the backs, that's what they have. If they can't fit it in a bag that they can carry, they might be wearing long sleeves and pants during the summer because that's all they have and they can't store it anywhere. All right, so just another thing to keep in mind. So hyperthermia is technically above 101. All right, so anytime you have a fever above 101, you are in a state of hypothermia. Okay, again, guys, if it's hot outside, if the humidity level is high, do we ever have high humidity levels here in Georgia? Never, right? It's all the time. My hair can tell you. If I step outside and it's like 90% humidity, it's just... all right. But why does a humidity level go into these heat emergencies? Okay, so it makes sweating less effective. You don't sweat as much. And even if you are sweating, it's just kind of counteracted with the amount of the moisture in the air. It doesn't really do its job as well. All right, so higher humidity levels cause that evaporation aspect that normally works when we sweat to not be as effective. Lack of acclimation to the heat. I got a story about that one. Vigorous exercise. What happens when you exercise or do physical labor? You sweat. Okay, so yeah, that does work for a little bit with the whole evaporation thing. But what do we lose? We lose fluid. We can become dehydrated. What also do we lose? Electrolytes along with that fluid. All right, guys, that's why they suggest you should alternate when you're trying to replenish your fluid levels, have a water, and then have something that's got an electrolyte supplement, if you will, like Gatorade or Powerade or Propel, anything like that, because we're not only losing water, we're losing electrolytes as well. If we have a significant electrolyte imbalance, your heart gets really pissed off. All right, so we can see some cardiac issues if we have a significant electrolyte imbalance as well. So yeah, guys, same with the cold emergencies, pediatrics, geriatrics, patients with comorbidities, limited mobility. Why? Same with cold. They can't physically remove themselves from the environment. They're just kind of left there to be exposed to whatever, hot or cold. All right, heat cramps. What's going on here? Anybody ever had these? No? Okay. How do they present? Okay, so they're painful, yes, but we see like muscle spasms, right? Why do we start to see these? Exact cause is not well understood, but we usually start to see these when there starts to become an electrolyte imbalance. There's a lactic acid buildup because of that loss of fluids and electrolytes. Have you guys ever seen that video of, I think it's just like a dude who works out all the time. He had an intense, he's sitting in his car post-workout. He's got his foot propped up on the dash and his calf is just like gnarly looking. You can have that intense muscle spasm or muscle cramp when it is heat related as well. Legs or abdomen are typically where we see these heat cramps. All right, heat exhaustion. What is heat exhaustion? Maybe. So we might can have a sinkable episode from heat exhaustion, but just what's happening? We're getting too hot. Our body temperature is getting too hot. We're sweating, so we're starting to lose some fluids. All right, guys, there's a big difference, and this is a big thing you need to take away from this chapter. There is a big difference between heat exhaustion and heat stroke. All right, so heat exhaustion are the early stages of this heat exposure. If we don't correct it, if we don't get removed from the environment, if we don't replenish those fluids, we'll eventually go into heat stroke, and heat stroke is not very good for your body. Okay, so dizziness, weakness. Sometimes you can see a patient have a syncopal episode. Sometimes they'll pass out. Nausea, vomiting is pretty common with heat exhaustion. Okay, what's important to know about heat exhaustion? How else are they going to present? Okay, what do you mean? Okay, so they could be pale. Sometimes they could be also what?
Flush.
Sometimes they could be flushed, just depending on maybe their acclimation to the heat or maybe their baseline blood pressure. But they're typically going to be clammy and cool, right? Because what's still working? What do we still have the ability to do in heat exhaustion? Sweat. All right. right? You still have that fluid volume to be able to sweat during heat exhaustion. So a lot of times they're going to have that moist, clammy appearance, and their skin is going to be cool because we're having that thermoregulation. It's still being able to do its job. All right. Dry mucosal membranes, right? They just have that cotton mouth sensation because we are losing those fluids. Vital signs are going to be typically normal. We're usually going to see a very slight increased body temperature and probably an increased what? Maybe respiratory rate, maybe heart rate. Okay. Now we move into heat stroke when we lose the ability to do what? Sweat. That thermoregulation aspect to our body is gone. It is depleted. It does not exist during heat stroke. Okay. So again, guys, if we don't get these patients out of this environment, if we're in heat exhaustion territory, if we don't remove them from the environment, if we don't replace fluids, we're going to eventually lead to heat stroke. Okay. Body temperature is significantly elevated. Guys, you are going to have significant altered mental status, confusion, totally unconscious, unresponsive, depending on what? What do we want to ask? Or what do we want to maybe look at? How long have they been out in this environment? What else do we want to have that goes into our scene size up for this? Where they are? What do you mean? Okay, so maybe a lot of times we see this in confined spaces that aren't very well ventilated. Okay, is my patient laying out in the sun? Like if they just got the sun just beaming down on them, or are we, somewhere that's covered, but we're not having any air circulation. It's not that, and that's going to increase that humidity level. Okay, size, stature of the patient. All right, those things all go age into my scene size up for this. Guys, you get so hot, you're literally, you start to boil from the inside out. Okay, your brain is scrambled eggs if you get significantly hyperthermic. When we start reaching internal temperatures of 105, 106, 107, your brain is literally frying. All right, if we start to see those neurological effects, we'll start to see seizures. You'll stop sweating. You'll go, typically guys, it goes seizure, coma, death for anything if it progresses to that point. Same with heat stroke. You guys might see a good bit of this during the summer. Why? How? Okay, so people might not hydrate. You'll probably see more so like, oops, I forgot to drink water, or, oops, I was working too hard in the yard. Probably that heat exhaustion territory. When do we see heat stroke? Where do we see heat stroke?
Maybe people have been placing their water with alcohol. It's exacerbated.
Okay, yeah, possibly. Because alcohol is a what, guys? Alcohol is a diuretic. What does that mean? It stimulates your kidneys to pee because alcohol is a what to us? It's a poison. So it triggers your kidneys to pee so we can excrete, so we can get rid of that poison from our system. So that whole, like, once you break the seal thing, when you're out drinking, that's a thing, all right? Once you start peeing, you're just gonna be peeing all night because alcohol's a diuretic. So yeah, we can get to the point where we're not replacing alcohol, or we're only drinking alcohol. We're not, having a drink and having a glass of water like responsible adult drinkers. But yeah, that could lead to it. What else?
Exercise.
Okay, so maybe like vigorous exercise, maybe somebody who's got comorbidities. Like, no pun intended, my blood boils when I have these calls, or when you hear about this. The hot car deaths. Yeah. Guys, it has gotten so bad. I can't fathom, like, I have 2 young kids. I can't fathom going somewhere and be like, whoops, I forgot they were in there, and just like forgetting that your child's in the car. I can't imagine. Obviously it happens because, guys, this happens a lot. I ran a couple of these calls myself. Like it happens during the summertime. That they, oh well, the car was cranked and it just shut off, and I was going inside of the hair salon to get my hair done. I was only in there 4 hours. It's not.
Only 4 hours.
Yeah. Or I just ran in the store for a minute and I caught up with Susie. I ran into Susie and we got to talking. I was only in there like a couple of hours. Or, I just forgot they were in there and I just went to work for an 8-hour day. All right, guys, this happens. What do we need to try our best not to do? Judge.
I was gonna say kill, but
That might be very hard in some of these cases. But guys, there was, the video was too long to put on here, but there was a vet of all people who he videoed this kind of study, this experiment. He sat inside of a car, and I think the car was even in the shade, or it was not even like fully exposed to the sun. It was like 85 degrees outside. He sat in the car, shut the AC off, had all the windows rolled up. And guys, within a matter of like 10, 15 minutes, he was sweating bullets and the internal temperature of that car had gone up to like 90 something degrees. All right. I think he tapped out of being inside of that car after like 30 or 40 minutes because he couldn't take that anymore. All right. It's not just the outdoor temperature. It's based on the fact that there's no ventilation inside of the cars when the windows are rolled up. If there's any type of exposure from the sun, because if y'all have temperature sensors in your car, it can be 85 degrees, but it's sitting out in the sun and it reads like 104 when you crank it, right? The same concept. I think in Arizona or something, somebody put cookie dough on a baking pan and left it in the windshield and like literally had freshly baked cookies when they came out of work. Bacon.
When do you get on a series on social media, try and bake different things?
That would be a great way for your car to smell really good. But guys, it's not just, it's only 85 degrees outside, they'll be fine. That's not how that works. All right. So we get a lot of co-responding calls with APD if they have to forcefully like bust open a window or unlock a car where a child was inside of a car. So with you guys being out there during the summer, that is very possible that you might come across that. I'm not going to attempt to get on a soapbox about that because I'm very passionate about that. But yeah, that's something you're going to come across. Guys, how are we going to treat heat exhaustion, heat stroke? Okay, can you give fluids? All right, maybe heat exhaustion, we can maybe encourage a little bit of oral intake, but not like let them sit there and chug a Gatorade. That's going to affect the status of my patient a little too much. Well, guys, what can y'all do? Okay, so again, guys, let's cut off any clothing. Okay, we're going to totally expose them, especially if it's any type of constrictive clothing, like any significant like workout clothing that has any type of compression to it. We're going to cut that off and we're going to do what? Crank up the AC in the back of the truck. We can place cold packs at those same junctional units, axillary, groin, and around the neck. But we need to be careful about that. Yeah, so we don't want to put those cold packs, just like we don't ever want to put ice like directly on top of skin. So maybe put a sheet or something that's a very thin material that's going to prevent that cold pack from coming directly in contact to the skin, but we still want to apply those junctional spots with a cold pack to try to cool them off actively. Once you go to A, you can give fluids. You can introduce fluids into the body. Once you go to A as well, we had this process of during the winter, we would keep the fluid bags and we would throw them in the windshield of the truck because where do the air vents come out? The windshield. So if it's cold outside, you're going to have the heat on all day in the truck, right? So if we ran a patient who was hypothermic, those fluids have been kind of warmed by the vents and we could give warm fluids. You might see like high-tech ambulances that have fluid warmers and coolers in the back. It's like a little microwave or like a little fridge, but we're not that fancy at Grady. So.
Improvise.
Yeah, we can improvise.
So if we're coming up on a car that's closed off unconscious patient, APD still on route, or can we incur property damage or
As long as you can justify what or prove what,
the life of the
that you're acting in good faith of your patient. Okay, so guys, coming on that, what are some things that we want to do before we go busting out a window?
Document level of the patient.
Let's knock on the window first, because the patient could be doing what? Taking a nap, right? If there's no response and we can tell maybe the patient is just profusely sweating or they're cyanotic or whatever it might be, what do our next step need to be? See if the door is locked, right? Try to open the door. And then if the door is locked, if we've still got, an extended response time for APD or fire, then yeah, we can go ahead and we can break that window to get the patient out, as long as we can prove that we were acting in good faith of that patient. Okay. So guys, here's just a comparison. The biggest difference is that we are not going to have any sweating with heat stroke. Okay. We're going to be altered with heat stroke. We're going to be in bad territory with heat stroke. Yeah, I had fire recruits come in. It was when I worked in the ER at AMC. I don't know why, but they decided that midday, like literally at like 3 p.m. in August in Georgia, they were going to have their rookie class, AFD's rookie class, do their live burn training. Yeah. Guys, we get co-responded, or we used to, I don't know if they do it anymore because of levels. But we would get co-responded to any type of structure fire. If AFD was on scene putting something out, we would just go and be on standby. We would hang out there for potential what? For potential patients, right? If somebody's inside that structure, if they have burns, if they have inhalation injuries, but also for who? The firemen. Why? Why can they get really hot? Okay, so they're in their turnout gear. Guys, that turnout gear does not breathe at all. It's designed that way so it deflects flames, right? So if you're literally running into a burning building, you want to have equipment and a uniform that can prevent you from getting burned. So that turnout gear doesn't breathe. What are they doing? Running into a burning building. All right, they're around extreme temperatures. Okay, just because that that uniform doesn't breathe and it doesn't allow flames to come in doesn't mean they're not doing what on the inside? Sweating significantly. All right, and guys, also too, it's a very physical task. All right, just the equipment that they carry, their O2 packs, any type of axes or anything like that, the hoses, guys, just their equipment packs like 60 to 80 pounds. All right, so doing all of that physical labor on top of being in a burning building or around flames, firefighters go down very quickly. All right, they have a limited time frame that they go in. You're in there for 10, 15 minutes and you're back out. You're cooling off. We're swapping in crews. You're making sure your O2 levels are good or your air is good type thing. So we're also there for firemen if they become a patient. Okay. But yeah, they did their live burns middle of August, midday. They brought in like 6 or 7 of the rookies that day. One of them was, I think his temp was like 107.2, something around that. He was seizing. They had intubated him. He was like throwing up around the tube. It was a bad day. I had never seen so many white shirts inside the ER because every single administrator with the AFD was in there because they had to do some damage control. So yeah, that was insane. That's the highest temp I've seen. But we also ran a call for APD during the summer. It was July. They were doing training. And we get on scene and this dude, he's probably like y'all's height, but he's probably like 280. And he's not like a solid, like strong 280. He's a fluffy 280. And we were talking to him. He had red hair, so his complexion was very pale. He was red as a beet when we got on scene. He was pouring sweat. and we're talking to him. He was definitely in that heat exhaustion state. And we're like, hey man, like just a small talk. Once we get him in the back, we're cooling him down, we're getting him some O2, and he's just like cooling off because of course PD was like, what did they say? Huh? Hey, are you good to kind of cool off and then come back?
Yeah.
Like he didn't want to be transported. We actually had to do like an AMA refusal for that. But yeah, we're talking to him and we're like, hey, so you're training to be a cop, like congratulations or whatever. And he's like, yeah, I got this job. I moved down here from upstate. And we're thinking like North Georgia. And I'm like, oh, okay, where are you from? Like New York. I'm like, oh, what part of New York? Oh, like upstate New York. And I'm like, okay. I was like, so y'all don't have summers up there like we have down here, right? Like the whole humid aspect. And he was like, no, it's usually like a warm, like 75. And I'm like, okay, well,
Welcome to Atlanta.
welcome to Georgia. But when did you get down here? He's like, oh, I just got in last week.
Oh.
So this guy was not used to the heat. He was not used to the humidity. Remember that lack of acclimation to heat? Yeah, he had never experienced anything like this. And on top of all of that, he's doing physical vigorous training for APD. So that can definitely be a thing. If you've got somebody traveling and they're not used to the elements, we can definitely see some exposure issues there. For heat exhaustion and heat exposure or heat stroke, what might we need to think about for ABCs? Vomit, so possibly suction, right? Possibly having them placed in like the left lateral recumbent, that recovery position. So we have that gravity be our friend. If they're vomiting, we don't aspirate. I'll take a little break. Yes.
Yeah. I'll tell a story.
You can tell a story.
Heat stroke.
Go for it.
I was employed as a backpacking guide on the Appalachian Trail. I had 12 teenagers and a camp counselor with me. And we're on top of this mountain, like 100-something miles away from the nearest city. And we run out of water on top of the mountain because our primary water source was disgusting and unfilterable, and then our backup was dry. So we're climbing down this mountain, and I'm like, man, I'm starting to feel kind of tired. Like, I bet these kids are tired. And like the last kid shares like his last little sip of water with everybody, and then I'm like, okay, still got like 7 miles downhill to go, and I start to realize like I have heat exhaustion. I'm like, ooh, these kids are probably not doing great, and I neglected to just point that out because there was literally nothing we could do but try to go faster. And by the time we got to the bottom, I was like going straight into heat stroke, and like I had stopped sweating. The kids, they did not look like they were
You turn around, Timmy's legs passed out on the trail.
like bright red, and then we just heard like the sound of rushing water, and then everybody sprinted and
Jumped into the stream.
in front of all these people, families and stuff, having their nice little vacations. Here comes
You're like dying in the street.
14 very hot, naked. They're absolutely filthy from being on the trail for 7 days. And just like jumping in the water.
Yeah. And guys, usually you don't realize that we're in that kind of danger zone until we start showing signs of that heat exhaustion, right? Like working out in the yard or running or doing whatever. You don't realize you're exerting that much until you get like, oh, wow, I just got like a wave of dizziness or type thing, headache. So yeah, it can catch up to you or sneak up on you.
I probably couldn't have told you what like 10 plus 1 was.
Yeah.
By the time we got to the bottom.
The school bus, because it was literally a school bus.
Imagine.
So much for CSA, huh? Student awareness.
What do you have a picture of?
Where?
It fell from that.
I picture my PFD too. The PFD saved for us.
I didn't realize he fell this close to the street. Just found him with one.
Friday.
The school bus was gone.
All right, guys. So more environmental drowning. All right, we're gonna see an increase of these cases and these calls. It's summertime. People like to go swimming in the summer. Might not be at the local pools because a lot of the community pools are not opening up to the public because of COVID. Pretty much the only thing you can do is like go out on the lake on a boat. So I think by even Friday or Saturday, Lake Allatoona or Lake Lanier already had 2 drownings. Was it Lanier? That place is cursed. Dude. I will never go do anything there. Hey guys.
No, it's just so busy. Everyone's driving.
So guys, there's 2 main differences when it comes to drowning instances. There's an actual like submersion event, all right, and then there's what we call near drowning or dry drowning. All right, so we'll talk about those. Risk factors for drowning. What do you think they are? Big one, really big one. Alcohol. Okay, again, you might overestimate or underestimate your ability to be a strong swimmer, right? Hey, I bet you I can go swim out there. I bet I can beat you, or I can make it there and back in less than X time. If you're not a strong swimmer, then you will fatigue. You'll eventually, not be able to keep yourself afloat. You'll go underwater. Again, with alcohol too, judgment goes down a lot, especially if you're doing any type of like jumping off a boat or jumping off a dock or jumping off of cliffs. You might not have that appropriate depth perception, especially if you're going head first. You might not understand that water is way too shallow, or you might not see that rock below you. If we have any type of significant head injury or spinal cord injury and we're in the water, what are we not able to do? Stay above the water. If we go underwater, we're going to be intaking the water in our lungs, which will eventually lead to drowning. Pre-existing medical conditions like a seizure disorder. If you just happen to be on a boat and you have a seizure and you fall in while you're seizing or because you seized, then that's going to be more predisposed for drowning. Unsupervised access to water. Who's this really account for? Kiddos. Okay. So kids can't really swim that well. I think there was actually, maybe it was a year or 2 ago, there was security footage of, it was at a hotel or like at a lodge or something. And there were a group of people in a hot tub. It was like 4 adults. And then there was a small like wading pool or another hot tub, literally like 10 feet from the hot tub where all the adults were. And there were 2 kids that fell in and were actively drowning and nobody noticed.
In Jersey, there was this past thing, this little girl, probably about 7. They have a pool. They just moved in the house on like Grammar Street. She fell in and was drowning, and no one in the house knew how to swim. So the mom got in, and she drowned, and then the grandfather got in, and he also drowned.
Yeah, guys, you hear about that a lot, especially in these lake incidents. If somebody's swimming out and they start to go under, their person might not be a strong swimmer, but they go out and they try to rescue that person, and they both end up drowning. Yeah, that happens, unfortunately, a lot.
When I was at swim, we always tell our kids, if you fall in, turn around.
Yeah.
You need to jump in and see the wall all the way.
And go to the other side.
Yeah, and then if they can't reach the wall.
Yeah. Guys, just a PSA, drowning is not always this loud, obvious event. Sometimes you can hear like some minor splashing, but you might not hear people like screaming for help or just like flopping in the water like a fish. Sometimes they just sink straight down and they can't ever resurface. So that's why I think one of those kids either died or had significant complications, and they charged because one of the people in the hot tub was their parents, and they were drinking, and they got charged with a big count of like child neglect or child endangerment or something like that. So it's not always a very loud, obvious incident when it happens. Guys, what's the main problem with drowning? Why is this deadly? Okay, so laryngospasm, right? But yeah, guys, we get that water in the lung, in both lungs. Okay, so if we're underwater and we're inhaling, that fluid's going to go in the lungs. We already know that if we have fluid in our lungs, what's not happening? Gas exchange, right? We're blocking that permeable wall, so that O2 can't be onboarded, that CO2 can't be offloaded. We're not having any perfusion, any oxygenation. Okay. We do have the laryngospasms. Have you guys ever gotten like splashed in the face, or you jump in the water and you weren't like, either holding your breath well enough and you get a little bit of water that starts to go towards your trachea? What happens? You start coughing, right? That uncontrollable, you get that laryngospasm because it's not used to being exposed to those fluids. And then also that uncontrollable coughing if you're having that laryngospasm while you're around water. When you're trying to breathe, you're taking in water as well. It's just kind of like a vicious cycle. Again, we can have these submersion incidences secondary to trauma. If somebody's diving head first and they don't realize that the water's super shallow, we've got to worry about ABC management, and we also have to worry about what?
Sure.
Yeah, that spinal mobilization. Guys, if you actively have somebody in water when you show up on the scene, we're going to talk about extracting that patient from water, but how do we need to go about doing that? What do we need to try to put them on? Put them on a backboard, right? The backboard's to float, all right? So we want to have the backboard. We want to try to pull the patient up on the backboard and then just use the backboard to kind of like float the patient out of the body of water if they're still there when we get on scene, okay? But there are several different things that go into that, and we'll talk about that more so before we just jump in and start throwing people on backboard, okay? But keep in mind, we can't have secondary injuries. We can have spinal cord injuries that has led to the state of unconsciousness or intake of the water. Remember, guys, we talked about like that compression injury with the spine. This is what we're going to see with these diving injuries, okay? You're going to dive head first. You're just going to be met, that momentum of your body diving with that shallow water. Your neck is just going to go like be compressed. Your spine will, the rest of your spine will as well. All right, so this is ideally what the book tells you to do if you have a patient who's actively drowning. All right, what does it say we do first? Reach. Okay, so if you're on a solid land or on a dock, reach out and try to grab the patient and pull them to that solid surface. Okay, what's the second one? Throw. This is the only one I would recommend. All right, if you have a flotation device, like a life jacket or like a lifesaver buoy, throw it out to them, tell them to grab on it. You can just kind of like reel them in like fish, right? What's the third option? Row. If you happen to have a kayak or canoe in the back of your truck, or guys, don't like hop on a backboard and get a splint and start pouring out to your patient. Technically you can, but I don't recommend it. What's the last option? Go. Swim out to your patient and rescue them and bring them onto dry land.
That's a good way to get drowned yourself, though.
Guys, why is throw the only one I would personally do or recommend for a stranger? Yeah. Has anyone ever had like a near drowning experience? Okay. My brothers I would be like in the deep end and they would like cannonball on top of me in the deep end and knock the breath. Dude, they were assholes to me growing up. But they would like, I would get the breath knocked out of me and I would like struggle and I would have that absolute panic mode to try to get my head above water and breathe in oxygen. Guys, it is sheer panic when you have any type of possible, hey, I might drown or hey, I might breathe in water.
For dive training, the most terrifying thing for me is when you're 30 feet down, they take your air source away.
Yep.
And you have to swim.
Do they jack with your mask too?
Yeah, oh, they will. Yep. Like, you just have to swim up. That was the one thing I had to do multiple times before I do, because I would just panic and then have to do it nice and calm.
So I guarantee you that if you have a patient who's actively drowning, they are going to do anything possible to try to get above water to be where they are breathing and they're not actively drowning. And that's going to include using you as a flotation device. All right. A couple lifeguards or previously or currently Yeah, guys, that's one thing that they teach you. You do not, I think you even do you approach from a below the patient or the back of the patient? Guys, they will grab onto like a cat that just fell in a bathtub. They will try to grab on top of your head. They'll push you down so they can get above the water. They can drown you by trying to or swim out to these patients or like reach and grab them. They're going to do anything possible. It's not going to be malicious, right? They're not going to say, hey, I don't like you, I'm going to drown you. It's just instinctive survival mode that kicks in. So do not become a victim yourself. We just talked about, you hear all the time, somebody, a bystander or a family member goes out to try to save someone who's actively drowning, and both of them end up dying because the other person gets pulled under.
Also with the throwing for certain devices, not aiming at the head is.
Yeah, try not to knock your patient out because then they'll go, yeah, you try to throw it, I think it's like 1 to 2 feet like in front of them. You're not gonna try to like, ring them with the booty. But yeah, guys, just don't, obviously guys, if this was somebody I knew or like a loved one or my kids or something, absolutely I'm jumping in there and going after them. But these patients who,
If you can swim.
yeah, I'm not like an Olympic swimmer or anything, but I'm a strong swimmer. But a lot of people think they're a strong swimmer and they're like, oh crap, too late now type thing. So this throw would be the only thing that I recommend just for the sheer purposes of you not becoming a drowning victim yourself. Okay. But no, the rhyming reach, throw, row, go in that order registry likes to know that you know that sequence. Yeah, guys, if you're not trained or don't have the equipment, don't try it. Recovery techniques, guys, there's rescue divers, there's swift water rescue. There's all sorts of people who are trained and have the equipment. So just like fire, when we're extricating patients or running into a burning building, you don't have the training or the equipment, we don't do it. Fair? Scene safety? Okay.
Funny thing I think just to do in this traffic is all the pulling out of the water. Like, it's like you're taking your gear off with your respirations as we're taking your gear off before we get on that.
Because of like the compression?
One of respiration, we can't get compression.
No, I mean like the pressure like surrounding it with all their gear and
Yeah,
stuff.
we have to take his gear off before we put him on our back, but the gear helps them float.
Again, cold water drowning victim. They're not dead until they're warm and dead. There's the mammalia diving reflex we talked about, can cause that instantaneous bradycardia and kind of go into hibernation mode. So again, we're still going to work these patients until their body temperature is up to normal. Descent emergencies. What does this mean? Okay, so pressure. Guys, the further you go underwater, the more pressure is on your body, is on your hollow organs, is on every aspect of your body, all right? I used to have that bad swimmer's ear, like I would get the water trapped in there and it just be kind of painful. I would jump in the bottom and go dive down to the bottom of the deep end at like a 12-foot pool. And just that pressure from 12 feet would cause my ears to hurt extremely bad. So if you have somebody who's doing like scuba diving who goes hundreds of feet below the surface, that's an immense amount of pressure on their body. All right, so we need to keep that in mind. If they're in extreme depths, all of the hollow organs, particularly the lungs, that tympanic membrane, remember those are susceptible to what other kind of injuries? Yeah, but when did we talk about pneumothoraxes and ruptured tympanic membranes?
Blast injuries.
What kind? Primary blast injuries, right? The pressure of the explosion itself.
And if they told you they were scuba diving yesterday and they flew on a plane that day or that next day, be concerned. Because you're not supposed to fly on a plane the day after you dive. You're supposed to wait 24 hours just because pressure from the bottom going all the way up in the air, that can cause some serious damage to your ears and your lungs.
See, I didn't know that, but that makes perfect sense.
Yeah, so you want to take them to somewhere that has a deep compression chamber.
There you go. So yeah, guys, again, if you could imagine being down 150 feet under the water and all of a sudden your eardrum bursts, or your lung collapse. All right, that's not going to be a very controlled ascent to the surface. That's going to be a panic. We might see some water intake. We also might see something else. That's going to be the opposite of the descent emergency. Sometimes if you run out of O2, you have like just straight up nitrous coming from your tank. You can have like hallucinations. You can have altered mental status. If you're at the bottom, again, that's not going to be conducive for an appropriate ascent to the surface. All right, so ascent emergencies. What is this? Okay, so decompression sickness. What do you also hear this referred to as? The bends. All right, what happens here? If we have maybe one of those emergencies at the bottom and the patient's panicking and they're starting to come up super, super fast. Like you're obviously going to know better than I am, but don't you guys have like a depth gauge? 50 feet? 30 feet. Oh, wow. See, I thought it was 50.
33 feet is what atmospheric pressure, so we stop every 30.
All right. So with a trained diver, when they start to come up, like she said, they have to stop every 30 feet and let their body acclimate to the pressure changes for 1 to 2 minutes.
1 to 2 minutes, we'll just swim.
Yeah, it's a gradual ascent. Because guys, that's a lot, that's a drastic, a roller coaster effect if you go from significant pressure to just all the way to the top. All right, if you come up way too fast, if you're not allowing your body to acclimate to those pressure changes, we can start to see nitrous bubbles actually form in the bloodstream. All right, they can get dislodged, they become embolized, they can go wreak havoc. They're very, very painful, but they can also cause some significant side effects. All right, they can wreak the havoc of any normal embolism. They can get stuck in different places, cause PEs, all sorts of bad stuff. All right.
It's more common on someone driving nitrous that's not experienced driving nitrous, because when you drive oxygen, once you're out, you're out. Like, people have nothing left.
Yeah, I'm glad I have subject matter experts in here today. All right, so again, this can be very, very painful, or this can actually cause like a PE. These patients need to be taken to a decompression chamber, a hyperbaric chamber. All right, that means they will place these patients in what you might see referred to in like some old timey movies, the iron lung, right? Their head is like popping out of the chamber, but the rest of their body's in there, and they can control, they can put more baro pressure around the patient. Yeah, they can put their body to the equivalent of the depth that they were at, and they can gradually control the release of that pressure to make sure that their body is acclimating appropriately. Unless this has changed, I believe the only hyperbaric chamber that we have in the metro area of Atlanta is at Southern Regional Hospital. Emory, Maine might have one, but I think Southern Regional is the only one in the city of Atlanta, and they actually use it for like wound care. But yeah, that would be something. If we had that type of emergency, I would get on the phone with supervision and say, hey, where do I need to take this patient? They need specialized treatment.
When people climb like Everest and under like extreme altitude mountains, they take like folding hyperbaric chambers, like a foot pump.
Really?
Yeah, so people have like high altitude
Sickness.
This is something
cerebral edema and stuff like that.
pressure goes down.
Put them in there, and then someone literally has to stand there like all night.
So yeah, guys, manage ABCs, have a sympathetic ride, have sympathetic transport, but these patients need to be transported to a hyperbaric chamber to make sure that their organs are not drastically affected. So there you go. Again, guys, your scene safety is the most important. If you cannot effectively remove your patient from that body of water without becoming a victim, we don't do it. Okay. What are we gonna do for a patient who's in cardiac arrest for secondary of drowning? CPR. Anticipate maybe more what? Maybe more vomit. Okay, so when we are giving those ventilations, if their lungs are significantly full of water, we're going to meet a lot of resistance. So it might trigger that water being expelled from their lungs. They might have vomiting going on. So just have that suction readily available. If your patient's hypothermic, treat them for hypothermia. But yeah, your numbers, your ratios, your depth, all of that stuff, none of that changes just because they're a drowning victim. Just anticipate more possible aspiration, obvious aspiration. Again, manage ABCs. Possible if it's a distension emergency, we could have a pneumothorax happening, but just make sure we're transferring to a hyperbaric chamber. Breath holding syncope. What happens here? How does this happen? Okay, so but why do you eventually pass out if you hold your breath too long? Okay, so you can run out of oxygen. What also can happen? Maybe.
Like hold it like really hard, you can like.
So if, especially guys, I don't know if we've talked about this, but especially if like you're bearing down or have an immense like pressure, what's something that you can stimulate? Yeah, we did talk about procedures. The nerve. Starts with a V. Your vagus nerve. All right, that's sometimes if you are, guys, it's the same motion as like bearing down if you're really trying to have a bowel movement. You can stimulate your vagus nerve and that can cause you to pass out. Okay, me, every time I like get into a legit like vomit, I stimulate my vagus nerve and I pass out. So it can be sensitive more so on other people, but sometimes we can have that happen. We can stimulate the vagus nerve and we have that state of hypoxia, we can have that syncope. If you're holding your breath underwater and you pass out underwater, good or bad? Bad. What are you going to start taking in? Water. Prevention, guys, we can't do much about that, right? We can have an educational moment or a teaching moment with our patients if they're not in cardiac arrest. Just be like, hey, probably should make sure you know how to swim if you're hanging out by a pool or a lake or going out on a boat, or maybe a little less alcohol. Like, we don't teach swimming lessons in EMS, but yeah. All right, so altitude, again, guys, we've got significant pressure that can cause issues, and then the lack of the pressure can cause issues as well. Altitude illness. Guys, what do we see here? What's happening here? So is there less oxygen in the air? So for the most part, the concentration or the amount is going to be mostly the same. But what's the problem? The higher up we go, the less pressure. It's more spread out, right? So the equivalent of me taking a breath here at whatever sea level we are in Atlanta, I don't know what we are. Anybody know?
Pretty close.
1,000 above?
Yeah.
I can get all the oxygen I need in one breath at this altitude level. If I go hike, not the equivalent of Everest, but a significantly high altitude, it would take, because I'm not right on these numbers, but it would take like 10 to 20 breaths to get the same amount of oxygen that I could get here with one breath at this altitude. All right, so we start to see issues with that. The lack of the pressure and the oxygen differential. All right, so acute mountain sickness. This is just going to be acute altitude sickness as well. We're not allowing, like, is there a particular rate that you have to ascend? You know what it is? No. Like, you guys can't run and like just sprint up a mountain. Just like coming up from the bottom, you have to allow your body to acclimate. We need to allow our body to acclimate with the less amount of pressure, the higher the altitude we go. If we're not doing that, or if our body's not used to this, we can just see dizziness, lightheadedness. We can have nausea, vomiting, fatigue. That's just where if you're hiking, you're like, ooh, I just got dizzy, I need to sit down. You need to let your body adjust and maybe move at a slower pace the rest of the way up. Loss of appetite. You might get very winded with not a lot of activity. Like if you might like take 10 steps, you're like, oh, I gotta catch my breath. So it's just the diminished pressure the higher up you go. Swollen face. Why might we see that? Why might we see some edema? Because that normally tries to help, obviously with other factors, but maintain the pressure in the fluids at the sea level. Gravity, pressure, right? If we have less pressure, those fluids are kind of more free to kind of expand and plump up a little bit. So we might see some swollen faces. All right, HAPE, high altitude pulmonary edema. What's pulmonary edema? Okay, fluid in the lungs. Why does this happen at higher altitudes? Chomping at the bit. Okay. So yeah, guys, this again is going to be with the lack of the pressure that kind of helps maintain all of the fluids where they need to be. We might see that the pressure, that significant pressure change, if it's a positional change, might cause this, what we call that flash pulmonary edema, to rapidly accumulate. So what are we going to see? How are these patients going to present? Anxiety, difficulty breathing, just like any other patient who has pulmonary edema, right? Lung sounds are going to be crackles, rales. We might see them coughing up pink frothy sputum, cyanosis, all that jazz. All right. Same with HACE. So we've got cerebral and pulmonary edema. Instead of the flash accumulation of the fluid in the lungs, we see this in the head and the brain. All right. This is a little, I mean, they're both not good, right? But we'll see altered mental status, loss of consciousness, headache, all that jazz. How are we going to treat these? Manage ABCs, right? At a national level, you can do what for HAPE? CPAP, okay? But just manage ABCs and recognize that it is an altitude issue. But yeah. Lightning, bad. Why is lightning bad? It's lightning. It's high voltage electricity. All right. So on top of the crazy like thermal burns and the injuries that we can have, what is a major concern if somebody gets struck by lightning?
Cardiac arrest.
Why? You're giving a major source of outside electricity to a conduction system that doesn't need an outside source of electricity, right? We can just kind of short circuit or fry the conduction system of the heart. Obviously, if you're outside when it's storming, you're going to be more prone to getting struck by lightning.
Also, just with high altitude stuff, people with asthma or
yeah, it's exacerbated.
Issues. Yeah,
definitely. Guys, this is why the rule since I've been a kid: if we hear thunder and we're swimming in the pool, we got to get out until it's not thundering anymore, right? Lightning follows thunder. We don't want to be in a body of water because it's a better conductor if lightning strikes type thing. So do it. Good Lord, bring it. Guys, with these lightning injuries, we're worried about the cardiovascular component, but we're also worried about the injury itself, right? Have you guys ever seen like an exit wound from a significant electrical burn? It can like bust out the entirety. Typically with lightning injuries, that electricity has to go somewhere, right? It has to ground out somewhere. So typically whatever body part is touching the ground, it will kind of course through the body and leave through that body area that's grounded on the surface, the flat surface. So, wait a minute, where did it go? Ugh. Maybe it's not on here? No. I thought I had a picture of an exit wound.
We saw some of the previous.
Oh, in the soft tissue?
Yeah.
Okay, that's what it was. But yeah, so guys, just to show you how powerful lightning is, this video, it's crazy. We'll watch and see what happens when a body of water gets struck by lightning. And then imagine this going through your body. So this is somebody's property. They've got just like a security camera. And I think it's right about here. There's a lightning strike that's caught on camera, but watch the ripple effect of that electricity being kind of grounded and transferred through.
Whoa.
That's why it's much more rare for someone to actually survive a lightning strike, because that's going through your body in your cardiovascular system. So no, usually good.
What does reverse triage mean? Since one of the goals of something that was use reverse triage.
Pretty much, we're gonna get everyone that we can removed from like the open area, so we don't have more patients accumulate. So we're gonna kind of, huh?
Isn't that what triage normally works? Is get patients out of that can get themselves out.
So yes, but typically if they're like too far gone, we just kind of leave them and we focus on the salvageable patients. So if at all possible, we want to try to get like everybody removed so we don't have more victims. Spider bites, guys. We've got down here in the southeast, the black widow and the brown recluse are the two really bad poisonous. It's not a neurotoxin. What is it? I had one of my students, he's in the A class now. Is it entomology?
Yeah.
Like he was all about insects. He was like my subject matter expertise when we were talking about this. I don't think it's a neurotoxin. It's maybe like a cytotoxin, something like that. It attacks the cells. But anyway, if we have the small black spider with the red hourglass shape on its abdomen, guys, I'm not gonna get that close to see that. Okay, that's just me. I can do spiders better than I can do snakes. I'm not gonna be looking at these slides when we have snake stuff, because just even seeing them freak me out. So, but yeah, if we have a spider that presents like this, then we are concerned about the integrity of the tissue from that bite. If it's just like a run of the mill, like a wolf spider, that sometimes gets confused for a brown recluse. It's gonna suck. It could become infected, but typically we won't see the significant damage to the tissue surrounding it. Black widows, they like dry, dim places. So like a lot of like wood piles are really common for snakes and for spiders. So be careful with that.
Right next to the bed.
Yes, thank you. I would burn the house down. So nerve tissues, that's what it is. Guys, these spiders are small, right? Both the brown recluse and the black widow, they're not large. So sometimes it's even like the initial bite itself doesn't get noticed. It's not that painful. Okay, we typically will see this like, a few hours or a day after the bite, and we start to see that degradation to the tissue surrounding it. But sometimes it's, unless they actually like see themselves getting bitten, they won't realize that the bite marks are there because they're teeny tiny. So with the black widow, muscle spasms, dizziness, sweating, nausea, vomiting, chest tightness. This is typically not going to be life-threatening like the brown recluse can be.
Limb threatening though. Can be limb threatening though.
Can be, yeah. Typically over 48 hours, if you're going to have those significant signs and symptoms, they'll usually resolve. But absolutely, guys, we do need to get these patients to the hospital because it is possible that we could have tissue damage, limb loss, all that stuff. These guys, on the other hand, these are much worse. These brown recluses. My stepdad got bitten by one, and on the back of his calf, there was just like a crater where they had to remove a bunch of the affected, the dead skin. So yeah, these will do some damage. It's not neurotoxic, it's cytotoxic. So again, we're going to really see just that necrosis and just the tissue death surrounding the bite. Again, we might not register the bite initially, but definitely when we start to see these signs and symptoms, we're going to realize that this is something's going on, right? So yeah, not painful at first, but within a few hours. Guys, what do we need to kind of notice when it comes to spider bites and snake bites and tick bites? We want to start noticing what, and maybe making note or marking what. Okay, so yeah, we'll see it particularly in, I think there is a copperhead bite, but we want to start noticing the ring of the area that's affected, right? We're obviously not going to mark this tissue right here, but maybe down here where you can start to see the redness is swelling, we might want to put a pin mark there and say, hey, at 11:28, this was kind of the parameter of the affected tissue, okay? And that 30-minute transport to the hospital, it could be getting bigger, or it could get bigger over hours. It's just going to give the hospital more of an indication as to how rapidly the tissue is becoming affected. So we'll look at that a little bit later. Venom, when it comes to flying insects or ants, right? We're only concerned about it when what? Your patient has an anaphylactic reaction to it, okay? This is if we do have a stinger still in the skin, what do we need to do? Try to scrape it out. We're not gonna like try to tweeze it out, but get a flat surface like your badge or credit card and just put it flush up against the skin and try to like just pop or scratch the stinger out. Why do we want to do that? Guys, as long as the stinger is still in the skin, if there is venom in that stinger, it will keep releasing it into the tissue. It's not going to kill your patient unless they're anaphylactic, but that's what hurts is the injection of this venom. So it'll cause your patient to be in less pain. Guys with spider bites that have not had a significant reaction like this or a sting, wash it with soap and water and transport if your patient wants to be transported. What should you not do for multiple reasons, but it actually works? Y'all can't be from the South. Don't suck it out. Don't suck the venom out. Is that what you were saying? No. Like chewing tobacco or dip. If you get that moist and you put it on top of the sting, it takes the actual sting, like the pain away, reduces swelling. Okay. Yes, ma'am. No. No, that's part of this. Yeah, no, okay, we will get there. Don't freaking do that. Do not do that. All right, so snakes, guys, we have a couple down here in the South that are poisonous. What are those? Water moccasin, copperhead. We do have rattlesnakes. Yep, we do have some rattlesnakes. Maybe if you're on the coast of Georgia, you can come in contact with some coral snakes that are poisonous. But we don't have a plethora of poisonous snakes like they do like out west, like in Arizona or the desert environment. Okay, so protect yourself from getting bitten. Guys, what's important to understand, even if you cut the head off of a freaking snake, it can still do what? It can still bite you. Okay?
If you like cut the venom glands and you have an open wound.
Y'all ever heard the term running around like a chicken with your head cut off?
Yeah.
Where does that come from?
Real life.
You guys ever seen like a chicken be beheaded? Okay, they will chop the neck off and literally the body without the head attached can still like run around. It's freaky.
Isn't the record like 9 months or something?
What?
There's
No
chickens
way.
that live months.
I don't know about that, but yeah, it's
9 minutes. I don't know about 9
really creepy. But guys, still, if you sever the head of a snake, it can still actively bite and release venom. So I don't care if they tell me, yeah, I took a hoe to the head, it's gone, like we chopped the head off. I don't care. Guys, do not effing go pick up the body of a snake and bring it with you. What?
Yes, yeah, that's.
What? We need to fact check that. That sounds great.
No, it's-
I made money off of it.
How did it eat?
They fed it with the dropper.
No.
Is that a picture of it?
Yeah.
That's gonna be, yes.
So yeah, guys, what can you do? Why would we want to bring the snake with us?
Know what's.
I mean, we don't, right?
Know what it's rated.
Okay, to know what kind of snake it is. So maybe we can tell, hey, is it poisonous? Do we need to get like some anti-venom readily available at the hospital type thing? What can you do besides taking it, putting it in a pillowcase and bringing it back to the truck? Yeah, take a picture of it. Okay, like way back, like get the nice zoom. Yeah, don't freaking bring a snake with you in the back of the truck. Don't bring a spider with you in the back of the truck. No, or like Steve Irwin, I got it in the pillowcase. So yeah, extreme caution and wear PPE, guys. Can a spider or a snake bite through nitrile gloves?
Yes.
Yes. Stay the F away from it. Like, please use common sense. Again, the snake bite's appearance is going to be 2 pinpoints, punctures next to each other. That's also what a spider bite is going to look like, but do you think those are going to be as noticeable?
No.
They're very, very small. All right, so the 2 pinpoint puncture wounds. Okay, so with the poisonous snakes, what are some differentials between poisonous snakes and non-poisonous snakes?
Triangular diamond shaped head.
All right, so the ones that are poisonous have a triangular shaped head, kind of like almost like an arrowhead, if you will. What else? Okay, their pupils are vertical. All right, they're just little slits. They are not round in shape. Am I going to be getting anywhere close to a snake to look at its freaking pupils? No. All right. So again, guys, if the snake is still on scene and it's alive, my scene is not safe, right? But yeah, I mean, we can ask the patient, did you look the patient or did you look the snake in the eye before it bit you? But yeah, just
You're rattling more stuff on.
so many no's about this stuff.
That's crazy.
Guys, rattlesnakes, they can grow very large in size. I think I was telling, we're on break, but my neighborhood backs up to WMA, it's the Wildlife Management Association, so it's like hundreds of acres, like they can't touch it. So we commonly have rattlesnakes that will come from the WMA and like end up in backyards and stuff, so we get really big, they're really creepy.
I was swinging on the swing set when I was like 7 or 8 years old, and I didn't realize it. And we had mulch, like our shirts, and my dog, my parents grabbed me, and my dog bit the head off.
Guys, their camouflage is creepy accurate. Yeah, we were last weekend. We were out. We were talking to my neighbors, and he has one of those Ring cameras. So, like, if there's motion detected, it like alerts you. Keep in mind, this is my next door neighbor. Like, we share a fence line. They were sitting inside, and it went off, and it was on his back deck, and it was a 3 or 4 foot rattlesnake that was like crawling across the camera.
Cool.
No. So they went outside, like, they killed it. But yeah, it
See the video of the people who like grabs a snake, shakes it, it's like 20 feet in the air.
They can reason do it.
Rattlesnakes, what's the most distinguishing factor of a rattlesnake?
The rattle on the tail.
You can hear it, all right? So it will rattle, it'll try to rustle up leaves, or I don't even know what's in, is it like fingernails, like
Yeah,
keratin.
it's keratin with little pieces.
It'll shake. So yeah, did you hear a rattle?
If you
before you
hear that,
got
don't
bit.
step on it or poke at it.
Copperheads, these are the ones that have the really, really good camouflage. It's ridiculous. You can Google copperhead camouflage and it's like you literally search the picture for like 10 minutes before you find it. It's crazy. Cottonmouths, they're typically going to be the very bright white, like when they open their mouth. That's why they're called cottonmouths. It's very distinctive, like a cottontail feeder, same concept. Again, pain at the site of the bite, nausea, vomiting, sweating, seizures. That's going to be coming along with a poisonous bite. Level of consciousness changes. Vision changes.
Just so keep in mind, just because the snake is venomous does not mean it actually used its venom when it bit you. It only happens like 30% of the time.
Oh no, they're all evil. They do it all. Again, locate the bite area, guys. For all of these stings and bites, wash it with soap and water. Mark the area, the circumference of the swelling. Manage ABCs and transport accordingly. Okay. We could have some type of anaphylactic reaction. Do not listen to this slide. Do not bring the snake with you. Yeah, guys, if we can determine the type of snake, we want to let the hospital know, hey, was this a venomous snake? Because they can go ahead and get the jump on having the anti-venom. Guys, it's not as rare as it used to be, but it's still very expensive. And it's in, huh? Yes, a vial. It's in limited quantities, and it's very expensive. So if we can get that ball rolling beforehand, then that's better for the patient. Coral snakes. What do we need? What's the saying about coral snakes?
Red touches yellow. And
Red on black, friend to Jack. Red on yellow can kill a fellow.
They also look like you just look at one and you're like, wow, that thing looks weird.
Yeah, I can see them from afar. But yeah, guys, they have black, yellow, and red color stripes and striations. If you have the color pattern where red is touching black, they are non-venomous. But if the red is touching yellow, they are venomous. So that's just because they are technically like on the coastal region of Georgia. That's the thing I grew up.
Only true for this part of North America, though. There are snakes elsewhere that have red, yellow, and black patternings, and the rules are not the same anywhere else.
There you go. If you're in the States, you can use the saying. If you're not, learn a new one.
Don't touch the snake, it's brightly colored.
So yeah, guys, this is what I'm talking about. You can see that the bite itself is down here, like on the ankle. And you can see kind of the bands of it moving. So when it's past, like where we're getting to the point where we're starting to see just that initial redness, that surrounding kind of that ripple effect from the bite source itself, we want to mark it and time it. So see, they marked right here 1625. This was the kind of parameter of the affected site at 425. So they can see how far and how quickly that venom is progressing. Scorpion stings, the suck. We have just a couple types down here in the southeast. I got stung by one when I was younger. It hurts really badly, but the types that we have in the southeast are not generally going to be any type of significant concern for a life status. I mean, go out in the desert, go to Australia, go to all of the different regions and hemispheres. That can be different. A scorpion sting or an animal sting can be deadly, but not the kind that we have here in the southeast. That's what they look like. They've got little pinchers right here, and then their tail curls. This is actually what they sting with. So
The smaller they are,
the more potent.
except unless you're here.
Right. Tick bites. Probably, if you've lived in the South for any period of time, you're probably aware of tick bites. These are little, hate these guys too. They're very, very small. They will attach themselves to the host, whether it's an animal or whether it's a human. They will keep their fangs embedded, and they will continuously suck blood from the host. All right, what's true about removing a tick?
Should get all of it.
You got to get the head. If you don't remove the head, because the body can detach from the head and it can grow a new body. But yeah, if you don't remove the head, it will continuously either suck the blood out or be introducing any type of diseases to that particular host.
Like Lyme disease.
Like Lyme disease. All right, so they're very small. Sometimes a lot of people confuse them for bed bugs. But once they've been on a host for a while, their body gets really plumped up with blood. So they grow in size the longer they've been feeding on a host. Rocky Mountain spotted fever. Got this from the Rocky Mountains down here in the southeast. Typically around a week after you get bitten, nausea, vomiting, headache. Sometimes this can lead to significant life-threatening issues with the cardiovascular system. So if you hike a lot, or if you're outside in tall grass or around bodies of water, you want to do a quick tick check when you take a shower. So, yeah. Lyme disease, this is also spread by ticks. They'll bite like an infected, like a deer or an animal, and then they'll bite the human. That can cross-contaminate. So typically, this is not usually going to be life-threatening. Maybe if somebody is like immunocompromised or has very poor health, it can become life-threatening. But usually you have like joint aches, you have body aches. It's not really, it's an inconvenience more so, flu-like symptoms. This is the bullseye presentation for the tick bite. So that's not the best presentation. You can kind of see right here, this little area is a little more white, a little more blanched in color. And then we have the red circles surrounding that blanched area. It kind of looks like a bullseye. So that will present with Lyme disease, the bullseye rash.
And if you have Lyme disease, nobody's going to believe you. It's rare enough that doctors will not believe you if you tell them you have Lyme disease.
Yeah, because it's not very obvious. It can mimic a bunch of other ailments, or like I think it said rheumatoid arthritis, flu-like symptoms. Yeah.
There's a antibiotic you can give to prevent it in a certain amount of period after a tick bite. And that was like one of the only medications I've ever been able to like actually
Administer.
I decided that you need this
Okay.
based on these medications.
More common in the summer. Again, guys, you gotta be. We typically don't try to remove the ticks. It's just a lot can go wrong. We can leave the head intact, but get a tweezer. Make sure you get the head, and then what do you usually do? Burn it, because those suckers don't die. Like you could try to squish it, and they don't die. So you typically burn it to kill it. Clean it with softened water. Bring the tick with you, guys. Leave the shit on scene. Like, don't contaminate the back of my truck. Like, I'll take a picture. That's fine, but no.
I think you can save them though, they can see if they have Lyme disease.
You can just like
That's great to know, but
don't have to
People,
clear
like,
tape
save
on
them
the
in the
truck, but
freezer
they'll
and
just take
stuff.
like clear tape,
no.
tape it to a car, and they'll write all this.
Okay, that's your choice. Marine animals, guys, we're not going to see a ton of this. If you go work like on the coast of Georgia, you'll see this obviously more jellyfish, sea urchins, all these types of things that can cause that can actually sting and or inject venom.
You see a lot of like coral rashes or like fire coral rashes. My brother had one on his knee and it's not the same color. It's like whiter than everything else. Rockfish, they're very poisonous. It's not on them, but they are very deceiving and very
Their camouflage is very
yes.
good. Yeah. Yeah, typically, guys, this isn't going to be life-threatening, especially that Portuguese man o' war. That can be like excruciating pain, but usually we won't see. Yeah, I mean, it does kind of look pretty.
But like
Yeah.
Aren't they like 14 feet
Yeah, they're very long, but then they're sneaky because the top of them is totally transparent. It's just that like the bottom part that's got that blue tint to it. Guys, what don't we do?
Touch it. Bring it.
Okay, yes. Okay, don't touch it. Don't bring it with you. Don't pee on your patient. All right. Has anybody not heard like or done that before? I'm not saying that it doesn't, but don't do it to your patient. Okay, a whole lot of lawsuits will probably ensue. Questions, comments, concerns? Everybody good with cold, heat, bites, stings, frostbite? Any questions? Okay.
Instructor
Zoom?
Instructor A.
Yes.
Mind if I give a little personal story about a rattlesnake bite?
Go for it.
So one rattlesnake they didn't put on there, which they should have, is a pygmy rattlesnake.
Pygmy?
And pygmy rattlesnake, they're small little buggers, but they can quite easily kill you. When I was younger, I picked one up, don't ask, and it bit me. And for whatever reason, I wasn't envenomated. But had I been, because of where we were in Florida, I would have had to been airlifted in a helicopter, and I still probably wouldn't have made it.
Ugh, pygmy rattlesnake.
Yep. But
Yeah.
They're fun. They're definitely fun, and they're all over Georgia. So.
Oh yeah, and two guys, the baby snakes, like I guess
Every time.
infant snakes, they don't yet learn they don't know how to control the release of the venom. So when they bite you, it's just like you just get a major dump of venom. So they're more problematic if you get bit by a baby poisonous snake. Another thing I was going to talk to y'all about the cold emergencies is paradoxical undressing. What is that? Why do you, a lot of the times, find these hypothermic patients totally naked? When you get far progressed into a hypothermic state, you get the sensation like your sensory nerves start to feel like they're burning. So due to the altered level of consciousness and the sensory nerves telling you that your skin is on fire, the patients feel like they're hot. They perceive that they are having that, hot environment, and they will take their clothes off because they will feel very warm. So yeah, that's paradoxical undressing. What do you need to do for that patient?
Get them in a warm environment and put the blanket over.
Let's cover them up with blankets. They don't need to be naked and cold. All right, everybody good?